Hello everyone, this is the Dr. Madhusudan Rao and the program I teach medical students. Today, the topic of my lesson is hemochromatosis. Hemochromatosis is a disorder associated with the excessive accumulation of iron, resulting in the multi-organ dysfunction. Hereditary hemochromatosis is the most common autosomal recessive disorder affecting the whites. When there is pathological levels of iron in the body, hemochromatosis said to occur. We touch this topic in terms of etiology, pathophysiology, clinical presentation, laboratory evaluation, and management. Before we touch the topic, let us see some of the pictures. This slide shows the liver in health and liver that is loaded with iron. This slide shows the pigmentation of the dorsum of the hands in the patient with hemochromatosis. There is a deformity of the joints secondary to the chronic arthropathy. This picture shows the normal liver, gallbladder, pancreas, and bile passages. Here is the picture showing the liver in hereditary hemochromatosis with iron overload and the normal liver in health. Okay. This is the degree of damage that is going to occur in patients with hemochromatosis with regard to the liver. Same thing happens in the different organ systems, resulting in their dysfunction. So, my dear students, you must be interested to know about what is hemochromatosis, what are the types of hemochromatosis, how do they manifest, how to make the laboratory evaluation and treat them effectively. As I told you, hereditary hemochromatosis is the disorder with excessive iron. Iron is commonly deposited in the liver, heart, pancreas, thyroid, pituitary, and adrenal glands. It is also deposited excessively in the joints, causing chronic arthropathy and the skin. Deposited iron in the cells in the form of hemosiderin causes cellular death, which is replaced by fibrosis, resulting in its functional loss. Hereditary hemochromatosis, as I told you, is the most common autosomal recessive disorder in the whites. Hemochromatosis is said to occur when there is pathologically high levels of iron. Whereas secondary hemochromatosis, also called erythropoietic hemochromatosis, occurs in patients on regular blood transfusions due to the treatment of these patients with regular transfusions in conditions like thalassemia and sickle cell disease. Well, as such, iron levels are tightly regulated because there is body is incapable of excreting extra iron. So, iron levels are well regulated in order to protect the body from excess of iron. Normally, when the iron is released from the hemoglobin of the destroyed RBC, is taken up by the macrophages. and carried to the liver and stored in the liver as transferrin. Iron released into the plasma is bound to the iron binding protein, that is transferrin, and carried to the liver where it is stored as ferritin. Some of the iron is utilized for erythropoiesis. Okay. When there is pathological levels of iron in the plasma, okay, it leads to hemochromatosis. Well, in hereditary hemochromatosis, an autosomal recessive disorder, there is excessive iron that is getting deposited in the organ systems. Well, what is the etiology? So, the iron that is retained is primarily deposited in the parenchymal tissues in hereditary hemochromatosis. Whereas in transfusion hemochromatosis, iron is deposited in reticuloendothelial organs. Okay. As I told you, iron is deposited as hemosiderin, resulting in cellular death, which is replaced by fibrosis. Okay. Well, coming to the hereditary hemochromatosis, it is four types: type 1, type 2, type 3, and type 4. In type 1, there is mutation in the hemochromatosis gene, an autosomal recessive disorder, prevalent worldwide. In type 2A, mutation is hemojuvelin gene. It is also autosomal recessive, common both in whites and non-whites. Presents around the age of 15 to 20 years of age. Whereas type 2B, mutation is in hepcidin gene. Hepcidin is a protein that controls the iron absorption in the gut. It is again autosomal recessive inheritance. Coming to type 2 is mutation in the transferrin receptor gene. Again, autosomal recessive inheritance. Type 4 is secondary to the mutation in ferroportin gene, which is autosomal dominant. If you look at these genes and molecular basis of this hereditary hemochromatosis is secondary to the mutation in the genes that associated with the different binding proteins for iron. Okay. So the defect in the binding proteins and their functionality results in the abnormal dynamics of iron in the body. Its absorption, binding, and circulation. There is excess of free iron getting deposited in the tissues because of the dysfunction of the carrying proteins. Okay. There is abnormality of the hepcidin, low levels of hepcidin which keeps check on the iron absorption at the gut. So there is excessive iron getting absorbed. Well, there is the defect in the ferroportin. Ferroportin binds the iron and carries the iron to reticuloendothelial organs. Okay. And there is a defect in the result, what you call transferrin receptor gene. Okay. And that again results in the free absorption of iron unchecked along the gut. So hereditary hemochromatosis is associated with the different types. Okay, with mutations of the various proteins that are associated with the iron metabolism, ultimately resulting in the excess of iron in the body. Epidemiology. Hereditary hemochromatosis is the most common autosomal recessive disorder in whites, and a prevalence of 1 in 300 to 400, very high. Type 2, 3, and 4 occurs worldwide, whereas type 1 is common in people of North European descent. Men are more commonly affected than women, and manifestations occur late in women than in men as they lose blood due to menstrual cycles. In men, symptoms occur around the fourth decade, whereas in women, they become symptomatic in sixth decade. Whereas in juvenile form, symptoms appear between 10 to 30 years of age. Secondary hemochromatosis is common among the people with transfusion-dependent hemolytic anemias. Okay. Coming to the pathophysiology. There are three important causes of pathological levels of iron. One, massive intake of oral iron, excessive absorption of iron in spite of normal intake, and increased production of iron due to massive transfusions. These are the three important causes of excess of iron in the body. Hereditary hemochromatosis. It is the result of the mutations in the genes controlling the protein molecules. That is, hemochromatosis gene associated with the HCF protein abnormality. There is a gene mutation associated with the production of hepcidin. There is a transferrin receptor gene dysfunction. And all these mutations results in the excessive absorption of iron, and in these hereditary hemochromatosis there is iron deposition occurs in parenchymal tissues, whereas that in the erythropoietic hemosiderosis or hemochromatosis, which is due to regular blood transfusions, iron is deposited in the reticuloendothelial organ system. Coming to clinical manifestations. Clinical manifestations basically depend upon the type of the organ affected. Okay, and the patient is asymptomatic for a long years. Nearly, it could be a decade the patient suffers before the diagnosis is made, because patient is either asymptomatic or symptoms are vague. Okay, and usually there is a history of severe fatigue and joint pains over a period of 10 years or more than that before the diagnosis is made. And in case of erythropoietic hemochromatosis, there will be history of individuals suffering from hemolytic anemias and history of regular transfusions. Okay. And in hereditary hemochromatosis, patient presents either with diabetes mellitus or present with the pigmentation of the skin, that is called bronze diabetes, and patient may present with these symptoms of jaundice or no jaundice. There will be hepatomegaly or no hepatomegaly, but there will be elevated levels of liver enzymes. And patient may present with symptoms of hypothyroidism. Okay, and there could be presentation of the gonadal dysfunction, with the loss of secondary sexual characters, presence of what I call gonadal dysfunction in the form of gynecomastia, and the patient may be losing scalp hair. Sometimes they complain that they lose the pubic hair too. And cardiac manifestations will be in the form of congestive heart failure. When you examine the patients, there may be dilated cardiomyopathy with the presence of third heart sound, etc. And the individuals with hemochromatosis, they are more prone for hepatocellular cancer. Okay, and there could be history of recurrent infections secondary to the dysfunction of the macrophages. Okay, and immunological impairment. Almost it is the clinical suspicion that is more important. When the patient has been asymptomatic for a long time, when there is family history of okay, this particular disorder, and high index of suspicion is very important in order to proceed with the laboratory evaluation. Serum ferritin levels are estimated in the patients. If serum ferritin level is more than 1000 micrograms per liter, it is of pathological significance. Then proceed with the liver MRI scan, liver biopsy in order to understand the iron overload, cardiac MRI, and echocardiography in order to assess the presence of injury to the myocardium or the conducting system. And go with the fasting blood sugar to assess the presence of diabetes mellitus, and go with about thyroid functional test in order to assess the functionality of thyroid gland, and other hormonal levels for hypogonadism, etc. The bone density studies are carried out in order to understand the endocrinopathies resulting in the osteoporosis. Then treatment. Hereditary or primary hemochromatosis is treated by regular phlebotomies. Okay. Initially, phlebotomy is done removing about 50 to 100 ml of blood. Okay. As frequently as 3 to 4 times in a week. Okay. Until the serum ferritin levels comes to normal. Then it is done about 3 to 4 times in a month, okay, in order to maintain the serum ferritin levels. And regular phlebotomies is going to prevent from the occurrence of cardiomyopathy and other endocrine dysfunctions. And the late presentation associated with the hepatic damage, liver transplantation is the option. But when compared to the success of liver transplantation for the patients with hemochromatosis and then those without hemochromatosis, the success of liver transplantation in the patients with hemochromatosis is much poor. Advise avoid alcohol. Well, coming to erythropoietic hemochromatosis, it is treated with the chelating agents. Okay. Then never forget to advise follow-up in order to find out the presence of hepatocellular carcinoma. Okay. Coming to a note on prognosis. Well, when the patient is untreated, There is progressive liver dysfunction going into cirrhosis, ultimately hepatocellular carcinoma, and disease in other organ systems. Early diagnosis treated with phlebotomies, avoiding alcohol and iron containing foods decreases the most of the complications in hereditary hemochromatosis. With the advances in the diagnosis and treatment, prognosis has been better than before. Well, presence of hepatic fibrosis and cirrhosis at the time of diagnosis is the limiting factor for prognosis. What are the complications? There are two important risk factors for early complications. What are the presence of hepatitis and chronic alcoholism? The complications that can set in a patient with hereditary hemochromatosis are hepatocellular carcinoma, which is nearly more than 70% common in patients with hereditary hemochromatosis, diabetes mellitus because of the injury to the pancreas, and hypogonadism and osteoporosis. Well, thank you very much, my dear students, for patient listening. This is the disorder which has to be suspected when the patient is suffering chronically with severe fatigue and associated with diffuse arthralgias. These patients are given some treatment other than in the form of iron supplementation, not knowing what exactly is the phenomena that is going on inside, and they are going to do more harm than good. And sometimes these patients they present with the features of anemia and koinonia. Okay, and they complain of severe fatigue. So normally treated with iron and vitamin C supplementations, and you are going to add fuel to the fire. Okay, it's not that every anemia is treated with iron. No, that's not the plan of treatment at all. Okay. Detailed history of the family members and presence of other organ dysfunction has to be identified before you treat the patient with iron. Okay. So, my dear students, keep this particular entity in mind when you are dealing with a patient with anemia. Hemochromatosis is the condition which has to be kept in mind and proceed with the laboratory evaluation so as to plan appropriate treatment to reduce the morbidity and mortality secondary to the multi-organ damage and their dysfunction in the patients with hemochromatosis. Thank you once again for patient listening. We'll meet you again next time. Until that time, this is Dr. Madhusudan Rao. Bye-bye. See you next with the next class. If you like my video, please subscribe to my channel. And once again, bye-bye until we see the next class. Thank you once again.